everyone. Moving on to the next segment, that is Hepatitis B and C, the new dog, new tricks. May I call upon chairpersons Dr. Harsha Sathichandra and Dr. Chatura Perera to call upon the speaker.
Welcome you all to this plenary. The topic is Hepatitis B and C, new dog, new tricks. Dr. Chaturapedi is my co-chair and myself will be chairing this session. The speaker is Dr. George Abraham. I think he's well known to the community of internal medicine specialists here. Dr. George Ibrahim, MD, MPH, MACP, FRCP. He is a professor of medicine, University of Massachusetts Medical School, Emeritus President, American College of Physicians, ACP, Emeritus Chair, Infectious Disease Board, American Board of Internal Medicine, ABIM. May I invite Dr. George Abraham to deliver his lecture on Hepatitis B and C, new dog, new tricks.
Greetings from the American College of Physicians. My name is George Abraham. I'm a past president of the college, and I'm grateful for this invitation. I apologize that none of us are able to be with you in person, although we would have liked to. We hope so we can do it at a future occasion. But for now, thank you for allowing this opportunity to share some information with you. I've been tasked with speaking about chronic hepatitis B and C, and I'm going to take you on a whirlwind tour of both since they are vast topics and we are short on time. So I'm going to keep this relatively short, just hitting some highlights along the way, which I hope will be useful to you. As we all know, hepatitis C continues to be an active disease in many parts of the world, acquired through either injections, contaminated injections, blood transfusions, or heterosexual or homosexual contact. And still, the larger majority of people are in the 40 to 50 range when they acquire disease. We do know that mothers in the reproductive age group are a risk group, and if they acquire disease, there's a potential to transmit to children. What's fascinating is that about 5 to 6 countries of the world who are most prevalent to have hepatitis C, about 30 countries account for 80% of hepatitis C infections in the world. And what's even more sad is that hepatitis C has overtaken HIV in terms of the mortality rates just from untreated disease. There are multiple modes of transmission. The only one I want to point out is the high-risk sexual activity, the fact that it's not primarily a sexually transmitted disease, but a blood-borne disease, and that the infection is primarily acquired through blood and not through heterosexual activity unless it's high-risk behavior. About 15% of people will completely cure. About 85% will go on to have chronic disease if untreated, ultimately leading to end-stage liver disease, and because it's an oncogenic virus, can have hepatocellular carcinoma if they are not treated. There are a number of extraintestinal manifestations which are listed here. Clearly, those are less and less now as we have treated more disease, but they do exist, at least for academic interest. This is probably one of the pet themes that is worth pointing out. The fact that the ALT, the liver enzymes, in no way correlate with the degree of liver damage. So a normal ALT in no way suggests or is reassuring of normal liver function. And in a landmark study done by Mitchell Schiffman, it showed that when you correlate it with biopsies, you can have all the way from no inflammation to cirrhosis. This has led to the fact that biopsies may not always be the gold standard, and people looked for other means of establishing liver disease, including using blood tests and what's now currently used called vibration-controlled transient elastography, goes by the trade name FibroScan, where essentially it works on the principle that if the transducer sends a sound wave through the liver, it creates a sound wave, and depending on the stiffness of the liver, so it's inverse of the degree of stiffness, because stiffness indicates fibrosis. So the stiffer the liver, the less the transmission, and that's recorded, and the machine is able to give us an idea of the degree of stiffness of the liver. from Boston at the Beth Israel Deaconess Medical Center. They published a paper, Dr. Nizam Aftal and Alan Bonder, who created what's called the Aftal-Bonder score, which has graded the degree of stiffness listed in kilopascal units and correlated that with the Metavir scoring system, the F0 to F4 for the degree of fibrosis, as listed here. And there are scores which are cutoffs for each stage in hepatitis B, hepatitis C, co-infection, and even with non-alcoholic fatty liver disease. It's the leading cause of liver transplantation still in the United States and probably worldwide, because hepatitis C untreated leads to cirrhosis, as we talked about. The big question has been who should be treated for hepatitis C. And in this day and age, we say anyone with hepatitis C, irrespective of the stage of therapy, the degree of fibrosis, should be treated, because if we do treat, we definitely make a difference. And why do we say it is worth treating? Because we have transitioned from the traditional interferon, pegylated interferons, to now directly acting agents or all oral therapy, where we have done away with side effects and essentially is one of the most seamless treatment options, where patients tolerate the drug almost exquisitely well and virtually no side effects, and short course therapy of 12 weeks, and they're basically cured with over a 99% cure rate. The virus genome has been sequenced, and there are multiple different sites at which medications act. Similar to HIV, we have now targeted more than one site, and our combination therapy affects more than one site to inhibit viral replication. And so therefore, the disease is well controlled. In the Clinical Infectious Disease, the Journal of the Infectious Disease Society of America, I wrote an invited review article talking about the first of the oral agents, sofosbuvir, which sort of has become the linchpin around which all treatment options have been developed subsequently, and continues to be the linchpin of treatment, which is worth referencing or reading, which would give you a better idea of treatment options. As I said, the genome has been sequenced. We have the various key enzymes, which when blocked leads to inhibition of viral replication, and the drugs that block these are listed here. This is freely available in literature, not worth memorizing at this point in time. Suffice it to say that there is occasional cases when these drugs don't work. Their response rates are 98 to 99%, but there might be that 1% who don't. And so we have a backup option with a combination therapy with sofosbuvir, velpatasvir, and voxilaprevir, which is the combination for people who fail the primary oral agent treatment. It's the same duration of therapy and virtually uniform success in all patients, so there is a cure. So there is a backup option. So this led us to write another invited review article in the same journal. I termed it Citius, Altius, Fortius, after the Olympic memo, which is faster, higher, stronger. And essentially that's been the motto in hepatitis C. How do you get treatment from 12 months of treatment to 12 weeks of treatment, from injectable agents with multiple side effects to oral agents with virtually no side effects? And how do you get people to cure? It's been really an amazing testimony and amazing story. A couple of other words about treatment. The mother-to-child transmission rate is about 15% with HIV and about 5% if hepatitis C monotherapy with a high viral load. And so cesarean section is not recommended, unlike HIV and hepatitis B, and that the mother can be treated at least in the third trimester starting, so as to decrease the viral load by the time of delivery, and that these patients can go on to complete their treatment, and the baby should be monitored to see if they develop hepatitis C. Recall, in the first year or year and a half, about 18 months of age, we don't test their antibodies, because they could have a passive maternal transfer of antibodies. And so therefore, they may be false positive. After 18 months of age, when the baby's own immune system is a little more robust, they are able to mount an immune response, and we should be able to see if they truly have antibodies of their own. There are recommendations to treat co-infected patients, which is HCV and HIV, and those regimens are pretty much the same as they would be for monotherapy. And in children, that is being worked out for now, but at least we look for drug-drug interactions between their HIV regimen and then adjust their HIV regimen to match so that there are no drug interactions with the hepatitis C drugs. So other than curing disease, what other benefits are provided by treating for hepatitis C? One is that definitely we know that it causes a dysmetabolic syndrome and metabolic dysfunction in the liver. And when you treat hepatitis C, especially in patients who have co-infection with diabetes or concomitant diabetes, that by treating the hepatitis C, we are able to significantly impact the diabetes and make them either reduce their diabetes regimen or some go off their medications completely. Additionally, there's now robust data to show that on a long-term basis, there's reversal of the fibrosis or damage in the liver, and that these patients go on to develop healthy livers and so are able to have a normal lifespan with less comorbidities by having treated them. As we said, hepatitis C is an oncogenic virus like hepatitis B, and so therefore, unfortunately, people do go on to develop hepatocellular carcinoma. This is especially so in patients who had cirrhosis at the time of diagnosis of hepatitis C. And if those patients have responded to treatment, they do need to continue to be monitored lifelong for the development of hepatocellular carcinoma by either ultrasound or CAT scan. And for hepatocellular carcinoma, there are a number of different agents in place, although that's really not the purview of our conversation today. There are radiosensitizers such as sorafenib, which are available. They do sensitize the tumor to radiation therapy. And then, of course, transarterial chemoembolization or TACE, where drug is delivered directly to the tumor through a catheter inserted into the hepatic artery or the branch of the hepatic artery. And like all other cancer chemotherapy, we're moving into the world of immunotherapy, which is more robust, which is more targeted, and might have lesser side effects than general chemotherapy. And so we're looking at immune checkpoint inhibitors, for example, nivolumab, which primarily came out for squamous cell carcinoma and lung carcinoma, but now is again one of those key drugs which have become the basis of combination chemotherapy in a number of different cancers, now being studied in liver cancer as well. With the advent of these newer agents in hepatitis C, clearly the regimen has become much simplified, straightforward, so that you don't necessarily need an infectious disease or a hepatologist or a gastroenterologist to treat hepatitis C. Even internal medicine specialists and other specialties who feel comfortable in protocol-driven treatment of hepatitis C can safely do it and help patients overcome the disease. Let's switch gears to chronic hepatitis B disease, which is probably much more prevalent and which you see every day, even in Southeast Asia, where there is still a high prevalence compared to the United States. Clearly, these are the countries. The dark green indicate the highest prevalence of disease compared to those with lower prevalence of disease. We know that unlike hepatitis C, hepatitis B is sexually transmitted. There is both mother-to-child transmission as well as horizontal transmission through sexual contacts, obviously injection drug use, blood and body fluid exposure, such as through hemodialysis or organ donors. In hepatitis B, what's fundamental to understand is the life cycle of the way hepatitis B works in the liver and affects the liver. Once we understand that, the treatment is so much more simple and becomes clear. So by definition, chronic hepatitis B is somebody who's surface antigen positive for 6 months or more. To assess the disease, we need 3 parameters. One, their hepatitis B E antigen status. E antigen positivity is in wild type virus, and E antigen negativity is in mutant virus, and where they lose their ability to secrete the E antigen. We need the ALT, using the ALT as a surrogate marker of hepatic inflammation, because we understand that the only way hepatitis B is removed from the liver is by immune-mediated necrosis of the hepatocyte. So there is a flare of ALT during active removal of virus. And lastly, based on these 3 parameters, their E antigen status, the viral load, and the ALT, we determine what phase they are in. So they could be in the immune tolerant phase, where basically there is no liver inflammation manifested by a normal ALT, an elevated viral load, and they are E antigen positive. They could continue like this for years. At some point in time, there is a triggering of an immune-mediated necrosis of the hepatocytes and clearance of virus. What triggers that, we don't clearly understand, but when there is an ALT flare, we clearly recognize that that represents immune-mediated necrosis of the hepatocytes, concomitant drop in the viral load, and there could be a fluctuation of the ALT called the immune clearance phase. If the clearance is successful, they go on to a quiescent phase where they become inactive carriers, where the ALT continues to remain in the normal range, but virus is also undetectable. These patients do need to continue to be followed because they're still surface antigen positive, because at some point in time they could reactivate, and the reactivation would be another flare of the ALT with or without an elevation of the viral load. They're always E antigen negative because that's mutant virus. And so therefore, the same problem as the immune clearance exists. The only phases we really intervene in is the immune clearance phase and the reactivation phase. We never treat them in the immune tolerant phase or the inactive carrier phase. The reason for that is we expose them to drug for long periods of time, but we never induce clearance unless there's an immune-mediated clearance. And so therefore, they would just be a futile treatment. The final resolution would be when they actually clear surface antigen. Surface antigen is a surrogate marker for hepatitis B DNA. When they become surface antigen negative, we know that they have cured themselves. And that time, then we can stop all treatment and monitoring. So this is may appear confusing, but is essentially a good algorithm to use to determine who to treat and who not to. So we use surface antigen as our initial screening test, either positive or negative. They're positive, they're chronic hepatitis B. We look for their viral DNA, that's either elevated or lowered. If the elevated viral load, we look for an elevated ALT or a normal ALT. If it's elevated, you check their E antigen status, as I mentioned. If they're E antigen positive, E antibody negative, they're in the immune clearance phase, definitely to treat. If they're E antigen negative but E antibody positive, again, that's reactivation, as I showed you in the previous slide. Both of these conditions require treatment. If the ALT is normal, even if they are e-antigen positive, that's the immune tolerant phase, we would monitor. If they are e-antigen negative, that's the inactive carrier state, we would monitor that group as well. If they're surface antigen negative, you always check their antibody status. Remember, unlike hepatitis C, hepatitis B, antibody, so surface antibody confers immunity, and so it's very important to see that they are surface antibody positive, because that would prevent them acquiring disease. If negative, you'd give them vaccine. If it's positive, you check their core antibody to check if they are immune from vaccination or if they are immune from disease. If they are core antibody negative, it's immunity from vaccination. Core antibody positive, they're immune from disease. Either way, all three don't need to be treated. As long as they remain surface antibody positive, life is good. As we well know that there is the Metavir scoring system, which I alluded to even in the setting of hepatitis C, and that's what is used now as the histological grading to determine the severity of fibrosis. The inflammation is really not the issue of fibrosis, which determines the progression to cirrhosis. And as we know, from fibrosis to cirrhosis, end-stage liver disease, which cirrhosis progresses to, and then hepatocellular carcinoma is a risk we need to address. Unlike hepatitis C, hepatitis B has a vaccine. There's monovalent vaccine given over 6 months as 3 doses. You can combine it with hepatitis A vaccine, which hepatitis A is a more immunogenic vaccine than hepatitis B, and the combination has a better immune response than monovalent hepatitis B. In dialysis patients, they require double dose of hepatitis B vaccine because they are considered immune suppressed. The current controversy is whether tenofovir disoproxil, which is the current tenofovir that's available, and the new drug, which is tenofovir alafenamide, which is a prodrug. It's a tenth of the dose. So instead of 300 milligrams of TDF, we give 25 milligrams of TAF. Once given, it actually gets into the liver, and there it gets converted to active tenofovir. What's the advantage? There's much less effect on bone, so no osteoporosis, much less effect on renal toxicity, and therefore much better tolerated at a much lower dose. I only put up the slide to show you that of all the different treatments that have been available over the years, if you look at the loss of surface antigen, which we said is the marker of cure, you see that even with the oral therapies, 3% or 6% is the maximum. So a very small percentage of people who actually cure themselves. And therefore, this is the downside of hepatitis B treatment. Once you start, you tell patients we may be treating lifelong. And so that's why this is the number one disease which is being researched worldwide, because looking for a combination of agents, much like we did for hepatitis C, would be the wave of the future. And the question is, why is it that it's so difficult to treat hepatitis B and cure it? That's because there is something called the covalently closed circular DNA, or cccDNA, which is archived within the hepatocyte, which is fragments of DNA, much like HIV, which is exactly similar. And so even though we get rid of it in the blood, the one in the hepatocyte may not disappear, and they can in turn develop daughter virions and reinfect or reactivate disease. This is why we cannot completely cure them. So like hepatitis C, we say, what's the value to treating hepatitis B? Clearly, there is a benefit in terms of progression to slowing the progression to decompensated liver disease. There are a number of mutations, but none of them are clinically significant. We don't really do mutational testing prior to starting treatment, and we always start treatment. The big thing in hepatitis B is reactivation of disease can occur, especially in the setting of immune suppression. So from a screening standpoint, we say everyone should be screened for hepatitis B, especially everyone before starting chemotherapy, because as I said, immune suppression can reactivate occult disease. And so immunomodulatory therapy, multiple different chemotherapy of all sorts can activate disease. We know that anything which affects the CD20, so classically rituximab, causes potent immunosuppression. And so we check them for their hepatitis B status always, because an entity called reverse seroconversion occurs, where somebody who's cured themselves or at least are hepatitis B as an inactive carrier, as soon as they get the chemotherapy, they can reactivate the disease, called reverse seroconversion. And so it's important to screen for that. Otherwise, you would be dealing with active hepatitis B during chemotherapy. So as I said, the work is all in terms of developing these new different modalities, drugs which might affect different targets of hepatitis B replication, ultimately working on something called cccDNA silencing, where we can get rid of that cccDNA, which would ultimately cause true loss of viral DNA from the hepatocyte and the loss of the surface antigen. And that's where all the research is. I'm optimistic that in our lifetime, we will see a combination of therapy which would make this successful. Thank you again for this opportunity. I apologize, this is a short and whirlwind discussion, but I hope that stimulated enough interest that you could research the literature for specific areas that you're interested in. And thank you for the opportunity to work together. Have a good rest of the meeting.
Thank you, Dr. George Abraham, for that excellent presentation on hepatitis B and C. Since it's a plenary, I will not be entertaining any questions, but on behalf of the College of Internal Medicine, we'd like to present him with this certificate, even though he's not present here physically.
Thank you very much, everyone.